Okay, so the recording started. Good morning and welcome to our series on our new community health profiles, overviewing the health inequalities and health needs of our different community groups. Today we'll be focusing on the findings from our 16 to 24-year-old student profile and discussing some of the health inequalities experienced by this group and what some of our next steps are. So I'm going to start the presentation by giving an overview of how we've defined the student population within the profile, some of the data used, the limitations of this data, and some of the demographic and geographical information. Then I'll discuss the key findings and some of the specific inequalities identified within the profile under the different health and wellbeing strategy themes. And then finally, I'm going to talk about how the profiles can be used going forward before we finish with a short Q&A. So before we start, just a bit of housekeeping. So please could everyone stay muted and turn off VPNs just to ensure the webinar runs smoothly. But do feel free to put your hands up and unmute if you've got any questions at any point. You can also post any questions you've got in the chat, and there should also be an anonymous Q&A section with the Mentee that we're going to be using. Slides will be uploaded to Birmingham City Council's website and under the Community Health Profile homepage, and a recording will be available on the Healthy Brum YouTube channel, and you'll be notified by email when the recording is available to watch. So we're going to be using Mentee during the webinar today to get your feedback and provide some opportunity for interaction, so you're not just like listening to me talk about inequalities for an hour. We'll just get everybody to get set up on that now, so you'll be able to see the QR code on screen, and the code to join is 13004513. We'll also be asking some questions where you might need a bit of time to think about or write out your answer, so can ask someone in the team to pop those questions in the chat now. So we'll get the first Mentee question done now. So the first Mentee question is, what's one thing you're looking forward to learning or discussing in today's webinar? I'll just wait a couple of minutes for people to respond to that and get set up on the Mentee. And you can also go back to the Mentee during the webinar if you want to. Okay, so people want an overview of inequalities, to understand the needs of the student population, understand some of the different issues they're facing and how to support them. Yeah, different students' health needs. So that's what we're going to be talking about today. So that's perfect. So we'll move on now to introduce the community health profiles. So what are the community health profiles? They're desktop pieces of research which summarize the published evidence, the grey literature, and population survey data, and provide a snapshot of the physical and mental health of a specific community, as well as the lifestyle, behavioural, and wider determinants of this. Each profile looks at the health inequalities throughout the live course, and information is presented according to themes that line up to the key priority areas identified in the health and wellbeing strategy. The general purpose of the health profiles is to move away from acronyms such as BAME and LGBTQ+, which tend to homogenise communities together and often overlook some of the huge differences in health outcomes between population groups. In addition to the profiles, there's also some census infographics that we've created that are shorter and more accessible summaries. And you can find out more about the background of the profiles at the link to the video that someone's put in the chat, that Jordan's put in the chat. So now we'll talk about sort of the background to the profiles, how we've defined the population in this particular community, and some of the geography. So looking at data collection, the profile focuses on the Birmingham student population that's aged 16 to 24. And there's a wide range of options for study available within the UK, depending on people's age and qualification type. And these range from level 1 to level 8 qualifications. Up to the age of 16, there's level 1 and 2 qualifications, which is things like GCSEs that are provided within secondary schools. And then you've got further education. So further education can be undertaken at any age between 16 and 24. this includes qualifications level 1 to 3, so GCSEs, A levels, BTECs, apprenticeships. And people can undertake higher education at any age after 18. This once relevant qualifications have been acquired. So that includes things like bachelor's, master's degrees, doctorates. That's levels 4 to 8 qualifications. The providers of these qualifications include schools, colleges, different independent providers, adult community education, the third sector, and universities. The profiles include anyone in these broad categories, and the profile will also explore the experiences of international students within higher education. The student population is very diverse, and where possible, the profile is also going to consider the intersectionality of being a student with things like gender, ethnicity, disability, and sexual orientation. There are some limitations with the data though, and we'll talk about this now. So firstly, there's limitations in the sources of data available, and then that makes it difficult to differentiate between different student population groups. So most studies focused on university students. So there's limited opportunities to understand the experiences of other groups, like people that do apprenticeships. And secondly, the student population is very complex and diverse. So it includes full-time, part-time, international students from all over the world as well. And the different groups within the population will face very different challenges and inequalities, and they might not all have the same experiences of education within the UK. So these experiences within education and also the wider determinants of health will also be influenced by factors like ethnicity, socioeconomic status, household income, disability, and sexual orientation. So generally, it's a very complex group, and there's quite a lot of gaps in the data, and that makes it hard to understand some of the experiences of that community. Moving on to the size of the population within Birmingham. So there were 7,903 students aged 16 to 18 in state-funded schools in Birmingham that were undertaking level 3 qualifications. So that's things like A levels and apprenticeships. Of these, 60% were doing A levels and 33% were doing vocational qualifications. Then when we look at apprenticeships, there were 4,740 people aged 19 to 24 undertaking apprenticeships in Birmingham. Of those 1,410, that's about 15% of that group, were under 19, and 35%, so 3,330, were aged 19 to 24. Then the much larger group within students is people in higher education. So there were 92,655 students within higher education in Birmingham between 2020 and 2021. 74,650 of these were UK students, and 18,005 were non-UK or like international students. You can see the breakdown of those students by different universities in Birmingham on the slide. So University College of Birmingham had the largest amount of non-UK students by percentage, and Newman had the lowest. Now looking at some of the demographics of that community. So when we look at the gender of students, generally there are more women than men enrolled as students in Birmingham across most student groups. So at level 3, 59% were female. In terms of higher education, there's more women than men enrolled at all of the 5 higher education providers within Birmingham, apart from Aston University, where there's more men. Looking at the intersectionality with disability, the number of higher education students in UK with a disability increased from 15% in 2017 to 20% in 2022. Looking at the intersectionality with ethnicity, Birmingham has a more ethnically diverse secondary school student cohort compared to national averages, reflecting the diversity of Birmingham as a city. So in Birmingham, for students aged 11 to 18 in state-funded secondary schools, 24% were white British. That compares to 64% nationally. 26% were Pakistani. That compares to 4.6% nationally. And 33.4% were Black Caribbean. That compares to 1.5% nationally. So in Birmingham, you can see that Pakistani students there's more Pakistani students than white British students. Then if we look at international students, in 2021 to 2022, there were 679,970 international students in higher education in the UK. That makes up approximately 20% of all higher education students. And Chinese students made up the largest group of international students in the UK and in Birmingham. So I'm now going to discuss some of the health inequalities identified within the profile. But before we do that, we're going to talk about the inequalities. But before we talk about the inequalities, we've got two Menti questions just to go through quickly. So the first Menti question is, how do you currently use health data to inform your work or decision making related to address health inequalities? So again, we'll just wait a couple of minutes for people to answer that. Okay, so people using it to inform strategies and action plans, proposals for new projects. Yeah, so that's the kind of thing we'd be expecting people to use data for at the moment within their work. Moving on to the next question. So we want to know how confident you feel in identifying the health needs of the student population. So at the moment, people are about a 2, and hopefully we'll be able to improve that over the course of the webinar. Okay, 2.3. Not bad. 2.2. Cool. Okay, so I'll now go on to actually talk about some of the inequalities within the profile. So for this section of the webinar, just for the nature of time, I'm only going to focus on one key piece of data from each of the sections of the report. That's to sort of show the types of findings that are available. And where possible, the presentation is going to highlight the best quality data. So it will use large-scale studies or national databases. But the data presented on the slides doesn't necessarily reflect the biggest areas of importance in terms of this community. It typically just shows inequalities where data is the strongest. And the slides aren't going to provide a comprehensive understanding of all of the health needs relating to the student population. Instead, it's just offering a start point for people to go and conduct further research. And it's suggested that everybody in the webinar goes and reads the full profile and uses any cited data for additional reading as well. With that said, we'll now talk about mental wellness and balance. So since 2015, the prevalence of mental health conditions among UK higher education students has nearly doubled. So in 2015 to 2016, there were 42,505 higher education students who were enrolled with a mental health condition. That's 2.3% of the total student population. But this has increased to 119,480 in 2021. That's now 5.5% of the total student population. So it's doubled in terms of the percentage. A large-scale study of 37,544 UK health education students investigated the prevalence of student mental illness within UK universities. That was in 2018. And there's lots of findings from this, but some of the main ones included 54% of students reporting thoughts about self-harm. 10% of these reported having these thoughts regularly or often. 76% of students with a mental health condition concealed their symptoms due to fear of stigmatization within university. And 45% reported consuming alcohol as a means of coping with difficulties in their life. There are lots more findings from that survey as well. One study identified factors that contribute to poor mental health in students, and some of these included transitioning to university life. So that's things like moving away from home and adjusting to new environments. Think academic pressure. So that's like the demands of coursework, exams, deadlines. Financial stress. So tuition fees, student finance, living expenses, financial instability. Especially that's worse for people who don't have support systems at home or at university. Also things like social isolation. So difficulties making friends when people move to university, or difficulties maintaining past relationships. There's lots of other significant health inequalities in this section as well, related to things like alcohol consumption, substance misuse, smoking and suicide. So I definitely encourage people to go and have a look at that. It's one of the main health inequalities for students. But now moving on to healthy and affordable food. So from a 2008 study from Newman University in Birmingham that was of 410 students, this looked at the prevalence of grouping of 5 lifestyle risk factors in students and reported 3 subgroups based on eating habits. The findings from this were that 66% of students ate less than the recommended servings of fruit and veg per day. But it should be noted, this is quite an old study, so it should be treated with a bit of caution. And it also shows the need for more research to fill some of those gaps in data at a Birmingham level. Another study, a cross-sectional study from 2013 to 2015 of 1,448 students who had an average age of 21.5 across 5 UK universities. This looked at dietary patterns of students generated from data on the frequency of food intake. One of the findings from this was that approximately 25% of students consumed pre-prepared convenience food most days or every day, and around 30% skipped breakfast most days. The study also found that unhealthy eating habits were associated with things like high psychological stress, low physical activity, and high alcohol consumption, and that social influences of peer groups often affected eating behaviours. In the 2019 health survey for England, among 16 to 24-year-olds, 28% of women and 14% of men screened positive for having a possible eating disorder. And approximately 32% of students with an eating disorder were diagnosed at university. Now moving on to look at active at every age and ability. So Sport England's Active Lives Adult Survey from 2020 to 2021 reported on levels of physical activity in 16 to 24-year-olds in Birmingham based on education status. So 66% of people aged 16 to 24 in Birmingham were considered active, which was similar to regional levels, which was also 66%, but slightly less than national levels at 69%. And being physically active was defined as 150 minutes of moderate physical activity. That's anything that raises the heart rate, such as a brisk walk. But it could also be defined as 75 minutes of vigorous physical activity, which is high intensity exercise, such as running. In Birmingham, those aged 16 to 24 in education had lower levels of physical inactivity at 26%, compared with those aged 16 to 24 who were not in education, which was 36%. So that's showing that people in education in that age group had lower levels of physical inactivity. Some of the benefits of physical activity from these different studies included 48% of people more likely to have higher mental well-being, 47% more likely to have higher personal well-being, and 25% less likely to feel social isolation. Now moving on to look at living, working and learning well. And within that, we'll specifically focus on inequalities around academic attainment. So when we look at the Attainment 8 scores, the Attainment 8 scores are a measure ranging from 0 to 60, and they show the average academic performance of a secondary school, calculated by adding together pupils' highest scores across 8 different government-approved school subjects. The average in Birmingham was 49 out of 60, and that's slightly higher than the national average of 47. But Attainment 8 was also shown to be affected by socioeconomic factors. For example, the score for those who were eligible for free school meals in Birmingham was 41, compared to 53 for those who were not eligible for free school meals. So there's a significant difference there. And the score was 42 for those who were considered disadvantaged. And the definition of disadvantaged there was either being eligible for free school meals or being part of the post looked after agreement, which is people who had been in care, guardianship, adoption, or some other arrangement with child social services. And that 42 compared to 54 who were not considered disadvantaged. So again, that shows a massive impact of different socioeconomic factors on Attainment 8 scores. Then when we look at Progress 8 scores, Progress 8 ranges from -1 to 1, where a score of 1 indicates that pupils in a group, on average, will make, it's a bit of a hard one to explain. Pupils in a group will make, on average, a grade more progress than the national average for students, with a similar starting point in year 7. So basically, from year 7 to 11, they will make 1 grade more progress than similar groups who were at a similar starting point. So with Progress 8 scores, the Birmingham average was 0.07. That indicates a slightly greater progress than the national average. But again, this was impacted by socioeconomic factors. So those who were eligible for free school meals scored -0.21 compared to 0.21 for those who were not eligible for free school meals. And those who were considered disadvantaged by that definition I mentioned scored 0.13, and that's compared to 0.27 for those that were not considered disadvantaged. So across multiple different measures of attainment, there's significant differences based on socioeconomic status, but generally Birmingham was on average scored higher on average than the national level. Furthermore, in 2019, 43% of people scored a strong pass, which was scoring between 5 and 9, and 62% of people in Birmingham achieved a standard pass, which is 4 to 9. That's for English and maths. That was compared to 43% and 65% in England, respectively. So the same amount were achieving a strong pass, but slightly less in Birmingham were achieving a standard pass. Those education ones are really complicated and hard to explain. Moving on to Protect and Detect. We're specifically going to look at sexual health. So young people aged 15 to 24 are the most likely to be diagnosed with the most common types of STIs. And some of the reasons for that include higher rates of sexual partner change. In Birmingham, the chlamydia detection rate in 15 to 24-year-olds was 182 per 100,000, and that's slightly higher than the national rate of 178 per 100,000. However, there's been a steady decline in the number of detected chlamydia cases over the past 10 years in Birmingham. In 2012, it was 2,300, and in 2021, it was 1,000. This could be due to different factors, such as the accessibility to timely testing, increased uptake of testing, and general changes to the accessibility of the screening programs. Now if we move on to aging and dying well. So there's fairly limited data in this section, but we will look at the mortality rates and the causes of mortality in 20 to 24-year-olds. So the mortality rates for 20 to 24-year-olds in Birmingham between 2017 and 2021 were 25.72 to 33.45 per 100,000. This was lower compared to the national average of 31.51 to 37.51. So mortality rates for 20 to 24-year-olds in Birmingham in this period were lower than the national rates. The leading cause of death in those aged 15 to 19 and those aged to 20 to 24 in England between 2018 and 2021 was suicide and injury/poisoning of undetermined intent. Mortality rates for those aged 20 to 24 dying from suicide and injury poisoning of undetermined intent in Birmingham in 2017 to 2021, those were 3.81 to 6.67 per 100,000, and that was higher than the rate for those aged 15 to 19, which was 3.76 to 5.03 per 100,000. So that's showing that mortality rates from suicide in the age group of 20 to 24 were higher than the age group of 15 to 19. Now, so that's the last of the different sections on inequalities. So I'll just talk a little bit about some of the inequalities that we haven't covered that are included in the community health profiles. So yeah, the significant health inequalities that we haven't covered within the presentation. For example, food insecurity was a big issue among students in this age group. So 44% of students included in a food standards agency study in 2023 were classified as food insecure, with the highest levels being in the Northwest, which was 60%. 16% of the general population in the West Midlands classified as food insecure as well. So 44% for students is significantly higher than the general population. Then there's significant inequalities around COVID-19 for young people, specifically in terms of their development, attainment at GCSE, and general worries about their future. So an ONS report on opinions from the Opinions and Lifestyle Survey in 2020 showed that around 75% of those aged 16 to 24 were unable to attend their educational settings due to the pandemic, and they felt that that affected their future life plans negatively. Yeah, generally there's lots more inequalities discussed within the profile, so I'd encourage everybody to go away and look at those. The profiles can be used to develop solutions, but they're not an exhaustive document that's going to map all of the experiences of all of students in the UK. As I mentioned earlier, there's quite a lot of data limitations. It's also important to consider the intersectionality with other groups and the influence of other aspects of people's identity, as well as just being a student. So now we're just going to do a quick check-in on the Menti again. So the same question, how confident do you feel in identifying the health needs of the student population? So it's at 4 at the moment. I'll just wait a minute or two for more people to answer. Nice, 3.7. So I think we were on 2.3 at the start. So I'll be happy with a point increase. 5. It's going down, that's not good. Okay, nice, 3.5. So that's like a 1.2 point increase from the start. Again, would encourage everybody to go away and read the profile. There's lots more detail in there if you're interested in understanding the student population a little bit more. So now we're just going to quickly move on to the last section where I'll discuss some of the next steps in using the profiles. So all of the profiles that we've created are currently in a draft version, so they can be edited. Would encourage everybody to go away and read them and provide us with feedback. For example, if you feel there's any inappropriate language used or an important report or data set that's not been included, then do let us know. All of the profiles follow the same outline template, but there might be a particular section that you think is more relevant for a different community. So do let us know if you think something needs to be added in. Or if there's a key health need or specific subgroup within a community that you think should be included. You can let us know via email. Jordan's already put that in the chat. And yeah, if you work with a particular community and provide a service to them, we can add your contact details within the appendix of the profile just to sort of help with promotion and signposting people to the right place. We're also happy to set up one-to-one feedback sessions if you would rather have a conversation with us rather than send us an email. So just get in contact and we can set one of those up. In terms of how we want people to use the profiles, so next slide, please. We'd encourage everybody to read them to build their knowledge and understanding of the health inequalities of the student population, but also to share it widely with their colleagues, wider organisations, partners, and different networks, just to encourage them to do the same. And the profiles can also be used as a tool when engaging directly with the communities, just to support them in advocating for change. We want people to use the data and the evidence in the profiles to inform and support new health interventions, new policies, new service proposals, but also to use it to justify the need for further primary data collection. So there's a lot of gaps in data on the student population, so it'd be great for researchers to use our profiles to justify further research. We're also keen for the profiles to provide rationale within funding bids. So anybody that wants to create a project that's supporting students, we want people to use the data that we've collected just to provide rationale for those. But that said, the profiles only offer headline data within each section due to like the breadth of information that's covered. So any additional sources of community intelligence should be used as well. Definitely encourage people to go away and contact the student population directly to understand more. So just a few more Menti questions now. So the first one is, how do you envision incorporating the findings and insights from today's discussion into your work or your organisation? And for anybody that's struggling to access the Menti, you can also put your answers to that in the chat if you prefer. Jordan's already copied the questions into the chat earlier on. I'll just wait a couple of minutes for this one because it's a bit of a longer response. Okay, we'll move on to the next question. You can still respond to this later on in the webinar and after it's finished as well. And we appreciate any response that you give. We'll use it to just to evaluate our profiles in the webinars as well. So the next question is, what ways do you hope to see healthcare services become more inclusive and supportive in relation to the student population? Okay. We'll just move on to the final question. So the final question is, what other intelligence would be helpful to inform your work or improve your practice? Okay, it's not looking like we're getting any responses, but yeah, just to reiterate, you can respond to this if you're typing it out. Oh, we have got one. Yeah, so research interviews with students. That's, yeah, definitely getting some qualitative data would be really useful, just to provide more context to some of the students' experiences, some of the inequalities that I've discussed. Finding out how many young people access support. Yeah, looking at ethnicity data within student data as well is very important to understand the intersectionality there. I think some of the things I discussed today show there's quite a lot of differences based on other factors like socioeconomic status, ethnicity, disability as well. So it'd be great to understand the intersections of that with the student population. More Birmingham specific data, as some data in the health profiles is national, yeah, definitely. And some of the data that is at a Birmingham level is quite old, like one of them was from 2008. So there's definitely a need to fill some of those gaps, get like up-to-date data on Birmingham. I mean, the fact that we've got over 90,000 students in higher education in Birmingham means it's a massive population group. It's important to understand their experiences. Lauren, could you flick back to the other questions just to see if there's any responses to those? Yeah, okay, there is. Okay, so in what ways do you hope to see healthcare services become more inclusive and supportive? So more training on inclusive language. Yeah, definitely. That's feedback that we got for some of the other profiles in the webinars as well. Sort of recognizing that health literacy is different in different communities. How people talk about different health areas is very different. So having better cultural intelligence, understanding how we can communicate with different communities is really important. Focus on disability and neurodiversity. Yeah, particularly with the student population, recognizing that the proportion of students in higher education is who have disabilities is increasing. So it's more important than ever to look at the intersectionality there. Training on how tech changes affect students' mental health, such as how phones can be anxiety inducing. Yeah, definitely. Yeah, things like social media, sort of how that relates to students' experiences at university, really important. Removing the stigma from students around having mental health. Yeah, I mean, I think definitely one of the barriers within universities is some of the waiting times for support around mental health as well. That's a big issue. Segmenting the population to understand needs. Yeah, just again highlighting the importance of looking at granular data for different communities and the intersectionality there. Could you just go to the first question, please, Lauren? Cool. So how do you envision incorporating the findings and insights from today's discussion? So using it to disseminate and consolidate and develop initiatives to further support students, planning services based on need and inequalities, taking into account specific needs. Yeah, so using the data to provide evidence for different policies, different funded projects, that sort of thing. Okay, thanks to everybody for responding to that. Now just going to close up. So we've had a range of other webinars on our most recent round of profiles. This is actually the last one, so we'd encourage everybody to go away and watch the recordings for those. That you can find them on the Healthy Brum YouTube channel. Jordan's just put the link in the chat for those. Before this wave of profiles, we also had a load of others as well, so you can find those on Healthy YouTube, Healthy Brum YouTube. Yeah, you can find all the links to chat in that. We're also doing an evaluation of the community health profiles. So we're conducting that with University of Birmingham, and we want everybody to provide feedback on the profiles and how they've used them. Jordan will put the link, or has already put the link to that in the chat. So what are we trying to understand through this evaluation? We want to understand the role that the community health profiles have played in different organisations and stakeholders in terms of informing their decision making. We want to understand how much confidence different organisations and stakeholders have in using the community health profiles, how accessible they are, how suitable they are for different work, such things like how useful the infographics are, whether there need to be more translations of them into different community languages. We also want to assess the impact of the community health profiles, as well as the subsequent community engagement partners. So we haven't got a deep engagement partner for the student profile, but for lots of the other communities we're working with, we're going to have deep engagement partners over at least 2 years, but more likely 3 years. We'll talk more about that in some of the links that Jordan's put in the chat. And if you have any wider questions, you can contact us on the community's email. So we'll just now, that's the end of the presentation. So we've got time for a few questions if anybody has any. You can unmute, raise your hand, put them in the chat, and I'll turn off the recording in like a minute or two if anybody would rather ask a question off the recording. Yeah, so I'll just let me know if you've got any questions. I'll have a look in the chat now. Okay, let's see, Elise is typing. Okay, no questions. That's good. Oh, sorry, Aurelia.
Yeah, well, thank you, because that was that was really interesting. I'm at Aston University, and I'm currently working on a project with students looking at their well-being. And it's I was talking earlier about the stigma, and especially with male students around mental health and well-being. You know, they don't really want to talk about that. They and it's just about kind of, I guess, finding ways to make the support accessible and available to everyone, which is sometimes difficult as well, because well, it's a bit of a vicious circle for some students, because they just feel isolated, and then they don't feel like they belong, and so they just well, they might drop the course, and so it's planning the kind of intervention early on, and support, making the necessary support kind of attractive, I suppose, so that they can take these steps before it's kind of too late already. So yeah, it's not really a question, really. It's just kind of a reflection more about. Yeah, thank you for kind of giving us evidence around that, because yeah, there's still room for improvement.
Yeah, I mean, it's a good point that you make, is the importance of early intervention, definitely, rather than catching people when they've reached crisis point. It's making it, reducing waiting times, improving just general, like you say, the appeal of services, people, reducing stigma, that sort of thing. And I guess that highlights the importance of doing research with students specifically, especially like qualitative research, to understand what some of those barriers are that they face, definitely, at a Birmingham level as well. Really important. Yeah, so that's a good point. Thank you. Does anybody else have any questions or comments? We can stop the recording now as well, if anybody would want to ask questions off the recording.